Hello, everyone. Welcome to the webinar, Advancing International Research in Residential Long-Term Care with Common Data Elements. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. We will be accepting questions through the questions feature accessible on the GoToWebinar panel. Also located there are downloadable handouts for today, a background reading list, and a copy of the presentation slides. While I introduce our speakers for today, please tell us who you are by answering the poll that appears on your screen. And hopefully you see that now. Yep, there we go. Presentations will be given by Adam Gordon, Professor of the Care of Older People at University of Nottingham, Kirsten Corazzini, Associate Dean for the PhD program at University of Maryland School of Nursing, and Michael Lepore, Senior Health Policy and Health Services Researcher at RTI International. So I'll give the audience members a couple of more seconds to select an answer on the poll so we can know who you are. And then I will hand the baton to our presenters. So after a couple of more seconds, I want to thank on behalf of GSA, Adam, Kirsten, and Michael for bringing us this important program. And I am going to show the results.
Okay. Excellent. So that looks like we have an audience of people that will have a lot to say about what we're going to present. Judy, can we have the first slide, please, if that's okay? Just seeing if I can see that on my screen.
Yep. Sorry about that. I'm trying to get out of here.
77% academic, 31% student, so that's quite an appropriate audience when we're going to be presenting some stuff about how to meaningfully collate research findings in long-term care. Now, I'm just wondering, I can still see the poll.
Yep, I'm sorry. If you can hold one moment, let me try to solve this technical difficulty here. Strange. Oops, my pardon. It looks like it's trying to reset. Oh dear. One moment. See if I can still get out of here. Let me try and switch this screen. There we go. Let me try this screen now.
I should say, for the benefit of the audience, that Judy's been phenomenally organised to try to prevent hitches, and despite the best laid plans.
Oh goodness, thank you for your patience. I hope you see the next slide now.
Me too, yeah. So I can launch off with this slide then, Judy. Long-term care, particularly institutional long-term care, is structured quite differently in different parts of the world. What you in the UK call, what you in the US call nursing homes, we in the UK call care homes, and different terminologies are applied to these institutions around the world. The way in which these are structured or funded differ quite substantially between countries. But what long-term care facilities do have in common is that the cohort of people who are frequently frail, who are frequently functionally dependent, who are frequently older, are very similar between countries. And this opens up the possibility to learn from the differences and similarities in practice between countries. But when you look at the international literature in long-term care, there are very few comparative studies where more than one country come together to draw comparisons between the work that's taking place in the long-term care sector. One reason for that might be the fact that we have no agreed sort of common data set or common set of variables to use when we're examining long-term care internationally. And given the similarities of the people that live in long-term care and that receive care there really should be a way to agree more standardized approaches. Can we have the next slide, please, Judy? So that really is the purpose of this programme of work that we're going to speak to you about today. We came up with the acronym of We Thrive, which stands for Worldwide Elements to Harmonise Research in Long-Term Care and Living Environments. Like any good acronym, it only vaguely resembles the words that it represents. But within that title, We Thrive, it captures a lot of really what it is that this programme is about. As we start to think about the things that we can describe and the things that we can measure across long-term care facilities internationally, we want to not just think about the things that are very easy to count, which are often deficits and care problems, but we want to also think about the things that might be a bit more challenging to collate data on. Next slide, please. And starting to think about this internationally, we've done 2 slides there, and starting to think about this internationally, we felt it was important to bring together a group of researchers from around the world. And so today on the webinar, we have US and UK representatives, but we also in the group have representatives from Norway, Sweden, and Australia, and Canada. And that's just the steering group. And what will become clear as we go through that there are a number of domain working groups which actually extend the influence of the We Thrive group beyond this small number of countries. I think one of the things to signal to you at this point is if you look at that group of countries, although part of our ambition of this project is to reach out to low and middle income countries, it will be clear to you that a lot of the steering group, in fact all of the steering group, are currently working in high income countries. And we can discuss this as we go through. We're working to address this, but this really is one of the challenges of working in this sphere. In a lot of low and middle income countries, long-term care sectors are just becoming established, and the research community is lagging even behind that. Next slide, please. Before Kirsten starts to describe the specific work of the We Thrive project and the We Thrive paradigm, I think it is useful to talk briefly about what core data elements are. This is a concept that's come from the National Institute of Health. It's now recognised in a number of areas around the world as being an appropriate ambition for researchers and clinicians to establish what should be a core data set. And I know that as someone that sits in grant panels here in the UK, I regularly see applications from researchers who want to develop or augment a core data set in their area. But the idea behind this is it's designed to promote standardized, consistent and universal data collection to ensure that people in different settings and different contexts are collecting similar data in a similar way so that the data can be aggregated to better understand and draw comparisons and contrasts, and the consequence of that to make research more efficient. Now, I'm hoping that this is not going to cause a technical hitch, but we thought this would be a good point, again, just to canvass some idea of who's in the audience. And we want to ask you, how would you describe your experience with common data elements? We'll just give you a minute or so, or a few seconds to answer that poll that's now appeared on your screen. Okay, and so we have some people with some experience of generating and using them, some people with no direct experience, in fact the majority with no direct experience, but have at least heard of them. And I think if we're entirely honest, that was the starting point for quite a number of members of the We Thrive group when we started this project, although we probably now come into the category of having some experience in generating them, and we hopefully soon will have some experience of using them in studies. So I think we're all at a similar point here. This is one of those all teach, all learn type scenarios. With that in mind, I'm going to hand on to Kirsten Corazzini, who's going to tell you more about the We Thrive programme.
Thank you, Adam. I think you're very correct to highlight the idea that that is essentially where the majority of us started as a consortium. What we did know, however, is that to begin our work together, we really needed to come together with an ontological foundation that what we wanted to create was really person-centered and strengths-based. That ultimately this purpose of advancing residential long-term care that could support resilience and thriving, and not just for residents in long-term care settings, but also for staff and family members. And this really represented an important shift. You can contrast that with the more common measurement paradigm that's really one more of frailty or deficits, often in the context of a resident in isolation of staff or family members, or staff and family member outcomes. Now, we can all think about how important that kind of disease-centric more approach has been in terms of advancing regulatory structures to support higher quality of care. But what the purpose of what we were trying to do was to really kind of expand our thinking from a more Western European or North American framework, and again, to flip it to this more aspirational resilience and thriving paradigm. Next slide, please. So we began to work concretely as a group. We came together at the 2016 GSA. We had a workshop where we started to think about what were the core measurement domains. If we were serious about this more resilience and thriving approach, being more inclusive beyond the kind of more North American, Western European approach, how were we going to do this? So we began with discussions, presentations, colleagues shared research that they'd been conducting, and ultimately came together in consensus among 4 key measurement domains, those being organizational context, workforce and staffing, person-centered care, and care outcomes. Next slide, please. From this point, we began to work in smaller subgroups around each of these 4 core measurement domains, and convened again as a larger workshop and working group at IAGG GSA 2017 in San Francisco. We had 47 participants from 17 different countries, beyond high-income countries as well, and we worked through a nominal group process to within each domain to prioritize key measurement concepts. And what you see on this slide is a summary of our ranked prioritized concepts within each of these 4 measurement domains. For example, in organizational context, social resources and support, regulation, funding, leadership hierarchy and role, leadership and management interface, and desirable working environment. So now this is another point where we really want to pause and invite everyone to take a couple moments to kind of look through what we are doing and reflect on what we've been doing. And Judy, we may have to flash back just a I guess if you've opened up the pool, we may not be able to. But given what we've shared thus far, what's your perspective on where we are with kind of our core measurement domains and these key concepts that we've been trying to, that we've elucidated and begun to work with? Does it seem on target so far? Looks promising? Maybe there's some gaps. Perhaps there's some really important points of disagreement or lack of clarity in what we're trying to do at this point. So I'll pause for a moment for you to kind of reflect on what you've seen thus far and share your perspective, hopefully segueing into a rich discussion once the more formal presentation part of the webinar concludes. And Judy, I'll leave it to you in terms of what the time frame. Oh, okay, great. Excellent. Okay, so it looks like just as we've actually been identifying as a steering committee, that while we see some really important ideas of sort of being on target, again, to Adam's point earlier about how inclusive has our process been, and at what point can we say it's promising, but there's still some important work to be done, and how can we begin to move forward in doing that work in more depth, in a more rich, inclusive way. And also to the point, I see a couple of people said, still a little confused. That's great, because as we go through and show some additional kind of emergent findings, I would hope that we can continue to dialogue and answer some additional questions. So next slide, please. So at this point, what became clear is that we needed to again, move beyond our steering committee group and the 2 workshops that we conducted as GSA and go into more depth in each of the measurement domains. And I'll just share a brief snippet from the organizational context domain. Next slide, please. So convened by Dr. Elaine Siegel, she actually brought together 11 experts across multiple countries, and you can see from this slide the kind of diverse representation to begin to understand how could we operationalize the prioritized concepts, social resources and support, funding and regulation. Next slide, please. And next slide, please, Judy. Thank you. And what the group found was that they actually needed to really engage in depth discussion about what were the key parameters that distinguished the types of residential long-term care settings beyond what we typically think of is, for example, a nursing home. And there's been really important international work in trying to operationalize an internationally relevant definition of nursing home. But again, in an effort to be inclusive, this group wanted to move beyond, take a step beyond that, and thus distinguish a residential long-term care definition. The group identified several key parameters to begin to distinguish among residential long-term care settings across these countries. You'll see one presented on this slide, types of and expected timeframes for residential long-term care services. Next slide, please. Another core distinguishing factor that began to help to move towards clarifying key concepts to operationalize organizational context was looking at kind of the range of dementia-specific services in residential long-term care settings across countries. Next slide, please. And finally, looking at the range and scope and enforcement of residential long-term care regulations. Recollect that at the beginning I talked about how in an effort to really propel forward a different approach to a measurement paradigm of one of thriving and well-being. In fact, this contrasts with a paradigm that has actually significantly advanced our kind of regulatory context in the US. Thus, it's not surprising to see that thinking across our different countries, the wide range. And I think at this point, I will say next slide, and I believe it's time to pass to my colleague, Dr. Michael Lepore. Michael?
Great, thanks so much, Kirsten. And so Kirsten's just reviewed some of the work in the organizational context domain, and I'm going to share a bit about the workforce and staffing domain. So within this domain, members of the consortium were led by Dr. Franziska Zuniga at the University of Basel. The group reviewed the literature to explore these concepts of retention and turnover among long-term care staff from an international perspective. Both retention or intention to stay and turnover or intention to leave are concepts that address the need to have a sufficient number and a sufficient skill mix of competent workers to care for long-term care residents. And these issues are particularly important because worldwide there's a shortage of nurses, including both registered and licensed nurses, which is partially due to high turnover rates and early exit from the profession. We can go on to the next slide, please. So the team reviewed, in the review of the literature, identified a variety of methods to measure turnover and to measure retention at the level of the long-term care organization or facility. These included examples such as using administrative data or using a facility-level survey. And then at the individual employee level, the review also identified measures of intent to leave the job or intent to stay in the job based on employee surveys. You go to the next slide. So in alignment with the We Thrive focus on measuring strengths rather than deficits and on parsimonious, ecologically viable measurements, the team's recommendations for international common data elements based on the review of the literature was to measure turnover and retention included a single item assessment of individual staff intent to stay. And namely, this would be an item with a Likert type agreement scale in which staff would respond to a statement like, I intend to stay in this organization for the next 12 months. And we could go on to the next slide, which will bring us into the person-centered care domain. So another consortium team within We Thrive, and this one was led by Dr. Jing Wang, who is now with Fudan University in China. This group examined the concept of person-centered care and conducted a bilingual literature review to examine this concept of person-centered dementia care in China. We go to the next slide. So the team systematically collected, reviewed, and synthesized key findings from the literature about person-centered care in China in both English and in Chinese. And I'd just like to note that this bilingual literature review method was very valuable because it allowed our team to do international research from our desktops without the cost of international travel. And now we can go to the next slide and share some of the findings from this literature review. Indicated that person-centered care has not yet been clearly conceptualized in China. In the Chinese literature, it appeared as more of an abstract concept in healthcare that's consistent with the value of building a harmonious society and promoting a human-oriented outlook. But person-centered care has not been clearly operationalized or applied in daily practice, and nor has it been included in quality of care evaluations in the Chinese literature. Studies did offer evidence that older adults in China value and desire autonomy, a sense of identity and meaning in life, and a sense of empowerment in long-term care facilities, all of which was consistent with the core concepts of person-centered care. The findings also indicated that implementation of person-centered care in Chinese long-term care facilities is just beginning to be studied systematically. And ultimately, there was much room for additional research on the concept of, on both the concept and the operationalization of person-centered long-term care generally, and person-centered care for people with dementia specifically, both in China and more broadly. We can go on to the next slide, please, and I'll pass it along to Adam to pick up on the outcomes discussion.
Okay, so I'll talk briefly about the outcomes work that we've done so far. This group has been led by Professor David Edvardsson, who is a Swedish person who works in Australia. So he manages to represent two countries at once, and I've been helping David lead this part of the programme. The eagle-eyed amongst you will recall from earlier in the presentation that there were in fact 5 domains within the care outcomes domain that needed to be covered, and these were symptom management, functional level, well-being, personhood, and harm-free care. And we were very critically aware as we started looking at outcomes that this was potentially going to be a very big literature, and we should sort of segregate this out a bit so that it became manageable. And so the first project that we started was around well-being, personhood, and I'll explain why quality of life came into that domain in a minute. And we are now, having completed this part of the work, currently conducting literature reviews around symptom management and harm-free care. So those are coming, but we started with well-being, personhood, and quality of life. Next slide, please. And the reason that quality of life crept in when it wasn't there originally, it came from us really trying to operationalize what we meant by well-being and personhood. And it occurred to us as we started to look at the dictionary definitions of well-being and personhood that they subtended the dictionary definitions of quality of life. And we felt that if we were really to do those domains due credit, we would have to base our literature search strategy around quality of life as well as well-being and personhood. Next slide, please. So what we did was we did a literature review using PubMed and CINAHL. You can see that we used search terms around well-being, quality of life and personhood alongside a number of synonyms which are available in the published articles, and we combined those with search terms around instruments, scales, surveys, questionnaires, and also words that signified long-term care or elder care. Now, as you can see, this generated a lot of citations. We had the resource of 2 dedicated Australian master's students who were able to wade through a significant portion of this literature, and they did a very targeted literature review. They weren't really reading much of the content, they were just looking for which outcome measures were mentioned across the literature. We then, from that, we found effectively 15 measures of well-being, quality of life and personhood, and we put it to our study group, so the 21 members of our care outcome group that represent a number of developed countries, but also critically Brazil as a sort of representative of low and middle income countries, to ask them whether the 15 measures that we'd found were sensible and whether we missed anything. And interestingly, at that point, they felt that there were probably about 3 measures that were missing from the list that we built, which were largely around social care related quality of life. Having built a comprehensive list of measures, we then asked our group, 21 care outcomes group members and 12 study steering committee members, to rank all of the outcome measures that we'd found in order, and then we aggregated the scores to effectively produce a top 3 under each of these domains, which are on the next slide, please. And so you can see that there are some outcomes here around well-being, around personhood. And what we really had to do when we looked at this in depth, and this came out of the group in committee stage discussions, was separate out quality of life from dementia-specific quality of life. Something that a lot of the group got very exercised about was a lot of the standardized quality of life measures did not perform well in people with moderate to advanced dementia. And I think this represents a real tension in these outcome measures as we start to look at how they might be applied. If you have a care home cohort, as it is in the UK, where 80% of the population have dementia, but 20% of them don't, how do you choose from this set of core data elements what you're going to use? And that's perhaps possibly something we can touch on in the discussion as we start to work out the next steps about how these actually work in practice and how they can be operationalized. But before we get to that discussion, I'm going to hand you back to Michael, who's going to talk a little bit about the next steps.
Thanks, Adam. So I'm just going to cover some of our primary next steps, ultimately aiming to expand our consortium of collaborators. It's really a primary focus for us. Also, some points about, the ongoing refinement of the measurement concepts, as we've walked through some of that work already, but there's much more to do, and a bit of a review on opportunities to actually identify and test common data elements in diverse settings. So I'll speak to each of these steps briefly before actually passing off to Kirsten to share an opportunity, our next opportunity to come together as a group. But if we go to the next slide, to first discuss our commitment to expanding our consortium and our group of collaborators, as both Adam and Kirsten have mentioned throughout. This is a high priority for us. We particularly want to include and meaningfully engage more long-term care researchers from lower and from middle income countries to help balance the high level of engagement of folks from higher income countries who have already been involved and will continue to be. We also are seeking to engage more diverse long-term care stakeholders in addition to our core engagement of researchers, looking to include residents and families in this work, ensuring their perspectives are heard, looking to include nurses and nurse aides who are core to the delivery of long-term care, as well as long-term care administrators and policymakers to the extent possible. Ultimately, the broader engagement will help make sure the data elements that are identified or recommended are as broadly useful as possible. And so hopefully each data element would be able to have multiple uses and keep the sort of data collection burden low across countries. Let me go to the next slide. So we're also aiming to continue the refinement of the prioritized measurement concepts, which is a lot of what we've covered today. And this will include additional review of the international literature about these concepts or that cover these concepts, and also additional review of measures of these concepts in diverse settings. We also are aiming to interview long-term care researchers from a variety of countries, as well as other long-term care stakeholders, not just researchers, but to understand the meanings of these concepts and making sure the meanings that we're using apply across countries and across diverse residential long-term care settings. So while settings might vary in name, they also might vary in content and the types of workers and the types of residents within them. So we want to make sure the concepts that we use are meaningful across those diverse settings. We can go to that next slide then on, finally, we ultimately aim to test these common data elements as they are identified and to assess that level of data collection burden that's so important to keep low to help maintain the focus on providing good person-centered care, and to test the reliability and the validity of selected measures, particularly aiming to do so in diverse countries. And we could go on to that next slide. So as we move forward, we really are actively seeking the engagement of early career and senior investigators from diverse countries to join us. And I'm going to pass it back to Kirsten, who could share some information about a next opportunity to meet just next month at the GSA annual conference.
Thank you, Michael. So We Thrive convenes under the auspices of the Systems Researchers and Long-Term Care Interest Group. So we do have an interest group meeting. I believe we have an early bird slot of 7 to 8 a.m. Thursday, 11:15 at GSA, and we invite any interested participants to please join us. And we'd love to continue the discussion and build on the discussion that we are about to embark on in the next, I believe, just under 30 minutes. So thank you.
Great. Thank you, Adam, Kirsten, and Michael. So we're turning now to the Q&A portion of the program. Just a reminder to everyone that you can type and send questions using that questions feature in the dashboard. It's probably accessible on the right-hand side of your screen. So as you're looking over there and thinking about a question to type in for our speakers, I'll clarify that we are not using the raised hand feature today. So if you have a question, please be sure to use that panel and type in your question. Another reminder to the audience, we're recording the session and we'll send you an access link by email along with the details of that meeting held during the GSA annual scientific meeting that you've been invited to. And those emails will follow the program today, so you'll have that on hand. I guess I'll ask the panelists if there was one important takeaway that you'd want to share with the group while participants are thinking about a question to send our way. Is there a takeaway that you'd like to share with the group?
So I think from my perspective, it's Adam here, one of the big learning points about this has been this idea of truly internationalizing the research endeavor in long-term care. And as we've reached out and tried to find collaborators, particularly in low and middle income countries, we found that probably more challenging than we'd initially anticipated. And I think there's something there about the way in which the long-term care sectors in those countries are developing, but also the extent to which the academic endeavour lags behind the development of the long-term care sector. And we're starting to sort of get the sense that some of the work we might be doing in reaching out is almost developmental, that by working with groups and countries, and I think about the group we've been doing with the work we've been doing with a group in Brazil recently, some of the work we've been doing actually getting collaborators for We Thrive has actually helped some of those members to start to identify as long-term care researchers. So I think my big take home would be that finding low and middle income countries collaborators can be harder than you think, but there is a developmental aspect in that you're actually generating capacity almost as you do the work. I'm sure Kirsten and Meg have things to add.
Sure, yeah. So I actually would say that to build right on what Adam was saying, I think my key takeaway from engaging in this process is it's very easy to say that we wish to be in kind of an inclusive consortium, but it is very humbling to have to sort of step back and think about how we typically, from a US-based research framework, think about nursing home settings and long-term care, to really broaden that, to really be thinking about residential settings, and how as those emerge across different countries in different ways, there's a really critical window of opportunity to have that discussion, identify what are those core. So if you're going to begin to emerge and conduct research in this space, what might be those kind of parsimonious few set of measures that we could begin to embed to really leverage and synergy across the work we're doing, regardless of country, and what that residential long-term care setting looks like, and the kinds of important questions we can ask to really advance quality of life and quality of care for older adults, their family members, and caregivers. Michael, do you have some thoughts?
Yeah, just hop in and also share that the opportunity to engage beyond our research community is particularly sort of ripe, as Adam sort of suggested, the researchers may not be identifying as long-term care researchers in places where there's little long-term care, but they may emerge to become so. And in contrast, citizens, governments, and providers might be more attuned to long-term care in countries where it's still emerging at this time. And so reaching beyond the sort of the academic partnerships and hearing the voices of long-term care users and providers, I think is a really important opportunity as this work progresses. And so that's one of the sort of expansions we're aiming for, is to hear more of those voices in confirming the importance of these concepts, the meaning of these concepts, and ultimately how to measure these concepts in a way that's meaningful for end users.
Great, and we have several questions now. I'll start at the top. Person-centered care has been conceptualized as ways of interaction, human to human, as well as an organizational change that involves systems changes. What is the focus of the person-centered care area in We Thrive?
So that is, this is Kirsten. I'll kind of start off the panelists on this. This is absolutely critical question. I think, again, thinking about back to the crew that have really comprised the steering committee, it's not a surprise that we began by thinking about person-centered care. And then as we sort of evolved and engaged more broadly with researchers based in other cultures and contexts, it really became clear that the kind of socio-cultural context of what we think of as person-centered is really important to consider. And that is, it really relationship-based care? Is it personhood? And you'll start to see in the work to move from domains to concepts to actually looking at potential candidate measures, that this is a discussion that's threaded across.
And I would just jump in to share some of, break down some of the concepts within that person-centered care domain. And Kirsten spoke to these, but I'd say the one that was ranked most highly was this, the concept within the person-centered care domain that was ranked most highly amongst participants at IAGG and GSA was this focus on relationships. And we had really robust discussion over a series of meetings about whether or not person-centered care would, the domain might more rightly be considered a relationship-centered care, given that concept of relationships really came to the top. But other aspects of that domain, other concepts within that domain that were prioritized were a bit more person-centric. So those included knowing the person and focusing on what matters most to the person. So we did stick with person-centered care as this overarching domain title, but the concept is more varied and does include sort of attention to relationships with the individual who's receiving care, the individual resident, and even is more broadly to include the environment, having a positive environment is part of this concept. And that part was ranked most lowly, but that also was part of the concept of person-centered care.
Okay, I'll move to the next question. My research focuses on the impact of volunteer programming in the long-term care community. Is there any consideration for how increasing community involvement impacts workforce, person-centered care, and care outcomes?
So, it's an interesting question of how these core data elements interact with a given intervention. I mean, I think there's certainly plenty within each of those domains. As we've sort of started to outline during the presentation, it could capture the impact and effect of volunteering. So if one looks at the outcomes, you could, for example, see how volunteering would impact upon someone's well-being and sense of personhood in a way that would be measurable using the types of domains that are included in the measures that we've started to include. And similarly, when we discuss some of those ideas about relationship-centered care and relationships that's oriented around the person within the person-centered care domain, they would certainly be able to capture a significant proportion of the impact from volunteering and the impact of volunteering in long-term care. I think what's striking to me is if you start there's a risk, depending on what your kind of research or if you're an academic clinician, clinical background is, there's a risk that you would come at something like volunteering with a very narrow worldview, in that you would view it particularly through a workforce paradigm, or particularly through a resident or person-centered care paradigm. And what the core data elements actually, I think, give us the potential to do is to ensure that everybody approaches the evaluation of a given intervention through a relatively broad lens and in a relatively standardized way. So hopefully what I've conveyed there is that the breadth of the approach and the relatively generic nature of the approach is such that we could understand the impact of something like volunteering in quite a comprehensive way.
Just to briefly really have one minor point to add to Adam's points is that some of the work around that organizational context domain that examined various aspects of long-term care, sort of high-level aspects of long-term care across countries, also could help distinguish how volunteers and paid workforce coincide or differ across settings internationally, with some long-term care settings in some countries may be heavily reliant on family members and volunteers to provide care, whereas in others that may fall more down the lines of strictly paid workers. So I think that also helps sort of contextualize those workforce and staffing elements. So I appreciate that question.
Okay, I'll move on to the next question. I did not see a category for self-care for long-term care staff and workforce. There are a lot of physical challenges, transferring patients, lifting, etc., but also loss with death and dying. Is it not important to have self-care as a component? Thank you.
So that's a terrific question. And I guess to me that nicely highlights the way in which working within any larger domain is really, we're very much, well, even just like, I'll take a step back. As we kind of introduced you to the work we're doing in each of the 4 domains, you was probably very easily discernible the differences across the domains in kind of the work and where we are. Even just the fact that each domain, we've sort of begun work with certain concepts, but not yet fully engaged in the work in other concepts. So when I think, for example, about care outcomes, we have symptom management as part of that, right? When I think about kind of self-management, self-care, and how that relates to care outcomes of symptom management, functional level, well-being, it is easy to imagine how critical self-care is and how those concepts ultimately become operationalized into a recommended or 1 or 2 recommended actual common data elements. And in fact, again, back to Michael's point about, well, we might sort of rapidly kind of sketch out several measures for, say, aspects of symptom management, but then, or functional, but then you sort of turn around and think about the diversity in context. So maybe self-care in relation to certain of these outcomes becomes really critical, and the one actual kind of candidate that actually could be implemented most broadly across these diverse settings. So I don't know if that kind of answers the question, but that's the first thing that comes to mind in terms of thinking about how important that is to thread in.
All right. I'll move to the next question then. Can you give us an example of how you would use some of these common data elements in a feasibility study?
So I think that question could be taken two ways, Judy. One would be to test the feasibility of the common data elements, and one would be to use the common data elements as part of a feasibility trial. I'm going to focus on the first one first. I mean, I think that if we take, for example, some of the discussions we've been having with colleagues in Brazil recently, it's not at all clear how easy it's going to be for them to work with the organizational providers of long-term care in their country to collect these data elements. It's also not clear because the cohort of people living in long-term care in their country is relatively poorly described, what sort of measurement attributes these sorts of tools and measures will have in the Brazilian setting. And so, I mean, the initial sort of feasibility work would largely consist of going and trying out some of these measures, perhaps with for no reason other than to just see whether they were feasible, whether they could be completed, the sort of time requirement involved in completion, then possibly some statistical work to look at the measurement attributes of the variables to see whether they worked within the population. Did they have floor effects? Did they have ceiling effects? What was the sort of distribution of scores, etc.? And then probably some qualitative work, perhaps working in a focus group way with care providers and, if possible, care recipients to understand the extent towards which the tools describe their experience of long-term care. And you can see how that could work for the sorts of measures that we're starting to come up with across all of these four domains. The additional challenge, of course, is when you move outside of English-speaking countries, is you have to translate these tools as well. And so a necessary first step before doing any work in non-English speaking countries would be effectively translating some of these tools into the sorts of languages where they could be used. I think that was actually the question that was being asked rather than something around feasibility trials. So I'll stop there. It may be that Kirsten and Michael have something to add.
Mm-hmm. Yeah, no, thanks, Adam. I think that makes sense. I mean, the latter question is actually probably a little more straightforward in that the idea of having the consortium kind of host a sort of suite of recommended items and data collection strategies, then it becomes fairly straightforward to kind of pop the individual common data elements into pilot work that you may be doing. And of course, the beauty of that is then suddenly your results become much more scalable, and you can begin to kind of ask questions that you wouldn't otherwise have been able to ask had those measures not been connected through kind of a common data elements approach.
All right. If okay, I'll move to the next question. We've got a couple more. Thank you for the webinar. It is very interesting when you talk about the potential stakeholders to work with. Did you think about including social workers in the nursing home setting? I think the measurement for turnover retention might also apply to social workers.
So that's an interesting question in and of itself, and that social workers in the care home setting, long-term care setting, will not be evident in a number of the countries that we are working with, just from the discussions that we've had. Taking even the UK as an example, those social workers interact with care homes, they don't work within care homes and often don't liaise with them on a very frequent basis. That would appear to be the case in some of the low and middle income countries we've been working with as well. So I think that may apply in some countries, but there's a significant number of the countries where we work where social workers don't do an awful lot of work within care homes. Perhaps Kirsten and Michael could comment from the American perspective, because I guess that is probably a US issue.
Mm-hmm. Right. So I guess I would say, thank you. That's really important, because it's sort of this idea of how do we acknowledge and really address the interdisciplinary environment of residential long-term care, with attention to both the diversity of professions engaged and disciplines, but also in the sense of what is kind of comparable across countries. I actually found this idea of kind of the critical role of social workers as popping up in maybe unexpected ways when we started to realize the big gap in thinking about kind of the social care context, right? So this idea that, again, that kind of humbling experience of starting from a very kind of North American, kind of Western European context of a nursing home, nursing and medical care, to then stepping back and thinking, oh, kind of the social care context. Now we have a whole different way of thinking about what does it really mean to kind of embrace residential long-term care settings. Michael, do you have some thoughts?
And yeah, just one additional thought, and I really appreciate this question as well. Another nuance of, say, U.S.-based long-term care is the distinction between those, within one long-term care setting, there are likely both long-term and short-stay residents, and the role of different professions, including social work, is varied based on, the sort of resident's length of stay, we might say, or the resident's needs. And so we might see in countries where short stays are more frequent, or in facilities where short stays are more frequent, that the role of social workers might indeed be higher than in others. But I really appreciate this, and I think it fits into, one of the concepts within our workforce and staffing domain is sort of staff skills. And so the mix of staff skills, or even professions, is definitely something that we're attending to. We had not called out really any specific types of staff, though I would say we were all there was a lot of thinking about sort of the nursing and nursing assistant staff, but not to the exclusion of social workers or any others. So I really, again, thanks for bringing that up. And I think it does have a lot of different value to consider, both domestically and then internationally, for the different types of professionals in long-term care settings.
Great, thank you. A core of person-centered care from the perspectives of regulators in U.S. is to include resident preferences in care provisions. Has that been represented in the concepts you've found in person-centered care?
Mm-hmm. Right. So, Michael,
yeah,
oh yeah, go ahead.
Yeah, I'll jump in with a quick response, and absolutely, I would. So, within each of the domains, approximately 5 or 6 concepts were identified and as priorities. There were lots more identified, but we sort of started with the top 5 priorities. And within that person-centered care domain, one of those top 5 was what we roughly called what matters most to the person. So I do think that was sort of at the heart of our thinking around person-centered care.
Okay. If there are no additional comments, I will end with this one last question. We have several others, but so I'll share with the group that I'll send the unanswered questions and share them with the panelists for answers following the program. But this will be the last one we'll pose on the hour today. How have you engaged residents of care communities in your work?
In this work so far, that remains our aspiration, and we need to do that. It's one of our goals for next steps. and we've been mainly engaging with researchers and then some clinicians as well, but we have not been engaging with residents yet.
Okay. Well, I've got other questions that I'll send your way for answers, but I'm afraid we've run out of time. Adam, Kirsten, and Michael, it's been a real pleasure learning about international research in residential long-term care, and we thank everyone for participating.
Yes, thank you.